is 23 in peer-reviewed journals and 41 presentations published in abstract form. He has delivered many lectures, including the Ready Lecture and the SLMA Oration 2021. She is the founder president of the GELSA, which is the Gaul Extracorporeal Life Support Association, and also the editor-in-chief of the Ceylon Journal of Ecmo, Cardiothoracic Surgery and Critical Care. In free time, she reads books, writes books. She has had 9 publications, both fiction and non-fiction. And I was pleasantly surprised to see that she is completing the MA in Pali language at the University of Kelaniya, Sri Lanka. And that was news to me. But thank you, and over to you, Tulisha.
Thank you, Guru. It's always a pleasure to do this every year. I am going to be a little more simple this time because there are going to be 2 MCQs. Am I right, Guru?
Yes, but we have now not doing the MCQs immediately after the lecture.
Okay.
Some technical issues, but we will use that MCQ for the final exam that they will be sitting.
Right. So because I thought I should simplify it just a little more this year,
Yes.
And get you a feel actually of what it is, because I think that will be more important, especially when you guys refer for Ecmo. So right. So so let's see how you all do the. I hope you do the MCQ as well, and even if you don't, I hope you enjoy this. So to be very philosophical, I think we'll start off. It is very easy to understand it this way. All things are impermanent and we will all die and someday, and normally we will die with irreversible cardiorespiratory failure someday. Now we know that cardiorespiratory failure, there are causes that are reversible. For example, meconium aspiration, myocarditis, or some forms of ARDS. Now, the problem is that even potentially reversible cardiorespiratory failure, we all know, can sometimes spiral into irreversibility. So, and before we can actually intervene. Now, we have seen these patients go into multi-organ failure, sepsis, and death. So, but if we could provide oxygen supply and by time for the pathology to sort itself out. This may be naturally, like say in meconium, it can, or it may be being treated, say in leptospirosis, or sometimes we just need time to bridge to transplant, or even to bridge to a decision in an emergency when we can't really figure out what the problem is, but we want to keep the patient alive. Now, ECMO can be used in this situation to give us some time. It buys us some time by keeping a patient alive. Now, so the objective of my lecture today has been, is to tell you as simply as I can about how and why and when ECMO works, and where we are today with ECMO in Sri Lanka and of course around the world. So these are the pictures, some of the pictures I'm showing is so that you can get a feel. This is the medical ICU where we tend to do patients like leptospirosis quite often. ECMO is actually a technique of temporary life support, which uses heart-lung bypass techniques for days or weeks to support the lung and the heart, lung and or the heart function. And this is usually in intensive care units and obviously in life-threatening conditions. Now, most of you will be familiar with extracorporeal procedures such as plasmapheresis, hemofiltration. And the principle is that we take blood within the patient's circulation and we take it outside to have a process applied to it. Then it is returned to the circulation. Now, when we talk about ECMO, it is important to understand the word extracorporeal life support. Now, this is the use of mechanical devices that remains outside the body to support life when native organs can't. And in the case of ECMO, the procedure done outside of the body is by using an oxygenator, which is the lung, to actively oxygenate and to decarboxylate blood. So the forms of extracorporeal life support are very varied. Cardiopulmonary bypass is one of the commonest and probably the most popular one for you. Then, of course, there is ECMO, ECPR, VADS, which may be LVADS, RVADS, and then the CO2 removal devices as well. I won't go into everything, but it's important to understand the difference between cardiopulmonary bypass as well as ECMO. So when we look at cardiopulmonary bypass, this is when the heart-lung machine is used in the operating room to facilitate heart surgery. And during this, it will provide total support to the heart and the lungs. On the other hand, ECMO is when extracorporeal life support is used in intensive care setting, and usually with extrathoracic cannulation, and it is to support respiratory and or cardiac function. Now, the term ECPR is also something you should know about because ECLS is used with extrathoracic cannulation while CPR is being given, and this is for emergency cardiac support. This is a growing field in the world of ECMO, so you should know the word ECPR. Now, the development of ECMO is very closely associated with the development of heart surgery and very specifically about development of oxygenators. So what you see here is Dr. Gibbon with this, who is the cardiac surgeon who started cardiac surgery as we know it by developing the heart-lung machine. And those days it was bubble oxygenators. So we went through many generations of oxygenators and to get to the membrane oxygenator. And what we have today is the polymethyl pentene hollow fiber membrane oxygenators, and they are very good. And these can be used for very long-term support. And without this long-term support, such as ECMO, would not have been possible. And the pump as well, it is a impeller pump, which is it's not the roller pump that is used in heart in the cardiopulmonary bypass machines, but this is a centrifugal pump, which is nowadays used most of the time for ECMO. This you have to know. This is about the ECMO system, which what do you need when you are talking about an ECMO system or the circuit of ECMO? So we have cannulae, which, and I will show you some pictures. Then the cannulae have to connect to the connecting tubing. There is a pump that pumps the blood. And there is an oxygenator that oxygenates the blood. And of course, we can also have a heater or a cooler to keep the blood temperature where we want, which is normally at normothermia. Now, it is fairly obvious to this group that if we are going to do this, you will need to also have heparinize the system. So ACTs are maintained at a lesser rate than in heart surgery. So it is important, as I said, to understand that ECMO is different from bypass. Now, what we see here is a heart-lung machine. And here we will have the cannula placed in the right system, in this case SVC, IVC, and it goes into a reservoir. And also when you operate on these, all this blood will also go into the reservoir. And all of this is then going through an oxygenator, and it is pumped through a pump and given back into the aorta. So this is a heart-lung machine. This is what you see in the theater. Whereas ECMO is a partial support, the cardiopulmonary bypass or what we use for heart surgery is a total support. And in these cases, when we're operating on the heart, we usually stop the heart. And we do this, just give me a minute. Sorry. What happens here is that we give cardioplegia to stop the heart, which no such thing happens during ECMO. So obviously ECMO is performed in the ICU, then heart operations are in an operating theater. And in the theater, we will take about 4 hours, maybe 3 2 to maybe maximum 6 hours usually. Whereas ECMO can go on for days, weeks, even months. So ECMO is a closed circuit. I will understand when I show some of the circuits, whereas this is not a closed circuit because this has got a reservoir, which is why when we operate, we can put all the blood into the, through the suckers into a reservoir and give it back. And for heart surgery, we need a higher ACT level, whereas ECMO we manage with very low heparin levels. And usually we maintain our patients normothermic in ECMO, whereas we are usually cooling our patients in heart surgery. So because there will be people who are quite familiar with heart surgery in this group, I thought I should just explain this a little more in detail, so that it's then easier for you to go from what you are familiar with to the what you are learning today. So the principles of ECMO is to provide, as you would have understood, gas exchange, oxygen, CO2. And in doing so, we are also arresting the injured lung and preventing it from having volutrauma, barotrauma, and oxygen toxicity. And of course, if you are supporting the heart and the lungs, it will rest the, as in VO ECMO, it rests the hearts and the lungs as well. So again here, you can see in the ECMO is like we have got cannula in here and they are going through the pump after being oxygenated and we are giving it back. Now here we can see why lung strain and thus lung stress will cause volutrauma, barotrauma, and it increases morbidity and mortality. And when the ECMO provides the gas exchange, we can rest the lung and we avoid volutrauma and barotrauma, and that is one of the reasons we can reduce the morbidity and mortality. We'll talk about it a little later as well. So you will often hear about VV ECMO or VA ECMO, these terms. And these are actually describing the cannulation modes. So when we say VV ECMO, we mean veno-venous ECMO. And this is a very common method which we use in our day-to-day ECMO practice. We place cannulae through the groin into the IVC and another cannulae through the neck into the SVC. So what is happening here is all this blood is going to be drained through the IVC, through this cannula into the, and it's going to be pumped through the oxygenator, where it is going to be nice and red and it goes back again into the RA. So what we are having here is a mixing of blood which will be pumped in through the aorta to the body. This is different from veno-arterial ECMO, and there are many forms, but basically we have to access an artery and a vein. Now what is shown here is we have cannulated the internal jugular and put one into the right atrium, cannulated the common carotid. The internal carotid goes in and that another cannula here. This is one of the common methods which we use in babies. Newborns, say in meconium aspiration, this is a common one which we use here. Of course, there are other methods as well. So this, as you can see, all the blood in the right atrium is drained, pumped, and then oxygenated, and it is given to the arterial system to be pumped right through the aorta and through the body. So when you say modes of ECMO, it basically means the main modes are the veno-venous and the veno-arterial. Now, when we talk about cannulation methods, it means how we put in place in the cannulae. Now here, these are very nice pictures showing the various cannulae which are put. So they are big cannulae, as you can see. One method is percutaneous, and intensive care doctors, cardiologists, they are very good with this, and they will be placing it percutaneously. Of course, there is the surgeons generally like, not well, often do open cannulation, and this is some of the pictures showing how we we dissect, we find the artery and vein, and then we directly cannulate this, like what is shown here. We commonly use, this is the method I normally use for newborns, an open method, and this is what the X-ray looks like. Now, there is something in between, which is called the semi-Seldinger technique here, where we place the, we dissect, we find the vessels, but we send the cannula through the skin. So there's direct vision, but we still use all the guide wires, and so that then it's just easy to take them off as well. That's just another method. So then you will hear the word about single lumen and double lumen cannulae sometimes, especially if you go abroad. Single lumen is what I have just been describing. You put one lumen for each cannula, right? So this is the, we call this the drainage cannula because the veins drain. We call this a return cannula because we give it. So it's easy to find out which is which because in the return, we have just one hole right at the end. In the drainage, we have multiple holes to allow it to drain. But still, these are called single lumen. As opposed to the double lumen cannulae, which are really fancy cannulae, they are so expensive. So we don't use it. The Avalon company has done a very nice, elegant double lumen cannulae where they drain the blood and it goes through the same circuit and is returned again uh, just opposite to the RA and the RV. And of course, you need some kind of imaging to place these cannulae in nicely. And in developed countries, babies usually get this double lumen cannulae for conditions such as meconium. But these are very expensive, and of course, you need imaging at your fingertips be able to do this. So ECMO is not a new entity for the world, although it's fairly new to us. In 71, the first successful ECMO patient this was the first successful ECMO patient. It was actually a trauma patient, and it was an ARDS patient after a very nasty motorcycle accident, and he survived, and he's the first survivor. Now, Dr. Robert Bartlett is considered the father of ECMO. And he did a lot of lab work and a lot of research, and he's still quite active. And early clinical trials, again in the United States, these were happening again in the late 70s and early 80s. So, and this first neonatal survivor, 1972, Esperanza, this was a landmark in the world for ECMO, the world of ECMO, because this is the first successful neonatal ECMO. Dr. Bartlett performed this for severe meconium aspiration. Now she's grown up, a young woman. Actually, she has kids of her own as well. So this was a landmark. Now, Dr. Richard Fermin traveled to the United States in the 90s, very early 90s, to learn ECMO and bring it back to the United Kingdom. And he was the person who did the UK collaborative trial on neonatal ECMO. And these were the studies that were made it possible to do ECMO in the United Kingdom because they were not happy just to take what the United States said, but they wanted their own studies before saying, okay, go ahead. So these trials were landmark trials for the United Kingdom to start ECMO. Now, coming back to Sri Lanka, it was actually serendipity that got ECMO in because Dr. Richard Fermin came to help me with the heart surgery, and we had a child we thought we thought it will be prudent to have ECMO before doing it. Guru will probably understand if I say this was a VSD and a parachute mitral valve with very severe pulmonary hypertension. Some people thought it was inoperable. Some thought we should operate. There was a debate, and the kid grew up to a young teenager. And by the time the kid came to to shown to Dr. Fermin. He said, yes, it'll work, but we should have a standby ECMO. This was a problem because we didn't have ECMO. And to cut a long story short, he basically convinced a company to loan us a machine. And that is how we managed to get an ECMO machine into Sri Lanka for the first time. And this was 2014. Now, finally, we actually didn't need it. The kid did well without ECMO, but we had a machine. So we thought we should start ECMO to do on patients as well. So just to talk about, we have three categories of ECMO: neonatal, pediatric, and adult. So we also started with neonatal ECMO, just to get you to understand. Say if we have severe, say, meconium aspiration with pulmonary hypertension, the kid is going to be really hypoxic and acidemic. There's going to be pulmonary vasoconstriction with high vascular resistance in the lung. It's going to decrease the pulmonary blood flow, which is going to make it worse, and more right to left shunting is going to happen. And this is a vicious cycle. And the moment you put that baby on ECMO, we break this vicious cycle because we increase oxygen, bring down the pH, which causes vasodilatation, and usually, and then the right to left becomes less, usually it reverses. And so we can support these babies like this. So we actually did the first ECMO patient in 2014, and the kid actually survived, but later succumbed to intracerebral bleed. So we again took many years to actually upgrade our neonatal unit. And Dr. Kapilani, again a batchmate of mine and Guru's, she worked very hard to upgrade her neonatal unit to bringing ACT machines and a whole lot of things and intravascular. We needed intraarterial monitoring, which we didn't have at that stage, and to upgrade the neonatal ICU to make it possible for us to do this kind of high-end babies safely. So, and all these efforts were, and also the other thing is, it was very important that we all knew what was happening, because one thing you have to understand, you can't do ad hoc ECMO. It needs proper training, and a lot of staff has to understand what is happening. So this is how we actually formed the JELSA. Actually, the reason was to train. So for her workshops for us to train, and a lot of work had to go into this. And all this hard work was rewarded actually in 2017 when we had our first neonate who survived and using ECMO. And this is a very bad meconium which survived, and this was the real landmark for us. And ever since that, we haven't looked back. We had quite a bit of publicity for this. And if you want to read the story, it is there in the Gall Medical Journal. So perinatal people were also very interested, and we did some presentations and some publications with them. Now, to talk about bigger children, very soon we were expanding our services within the hospital, of course, to bigger children. This shows some of the work we have done in the pediatric the PICUs. And as you can see here, this kid, now you can see this is an open technique of cannulation. So these are done in those ICUs. And we had bigger kids, again, some publicity here. This is a kid who had chlorine inhalation, admitted to Lady Ridgeway, and then was transferred here. We had to put her on ECMO, and that was turned out quite well. And again, her story, if you're interested, is published in Perfusion. And we have also presented it in India as a case report. And also, this acute severe asthma is actually a very important and growing indication for ECMO. This is one such kid, again in the PICU, which did this. Is published in our own journal. This is available on Sri Lanka Journals online. So if you're interested in pediatric ECMO, this is a good case for you to read to get some added insight. So adult ECMO is what we are doing most of the time. And this is our first ECMO was actually in adults was for leptospirosis. And because what happened was when we were doing neonates, the physicians and the intensive care doctors approached us in around 2017, 18, because from down south we had this epidemic of leptospirosis. So these physicians had read about leptospirosis in the journals, and they came and said, "Oh, we heard that you are doing ECMO for kids." And that what they said is, we are losing a lot of farmers, young adult men who just bleed into the lungs. And there are a case report or two in the international journals saying that ECMO has worked. So what they came and told us is, can you try this for adults? So we said, okay, we'll try. And so this is a very minimalistic circuit we tried on with our very first adult who was dying, and it actually worked. Now, this is why I'm saying minimalistic, was at that time we didn't really have the stuff to do ECMO for adults. And this was the head I used for demos. So this young man was just basically turning blue and dying. So we put this in Sidex, set up a circuit, and we tried it. And immediately he's oxygenated and carbon dioxide stabilized. Luckily for us, he didn't get an infection, and he survived. So this was a very important landmark for us to do adults. And again, we've never looked back since then. The story of this adult ECMO again is published in our local journal for anyone who is interested. And again, this is available on Sri Lanka Journals online as well. Because we are in Sri Lanka, this is also something you should know when talking about ECMO in Sri Lanka, is that a very interesting thing is we actually have the highest number of leptospirosis patients on ECMO. Now, I know this is very, very strange why this is so, but if you look at this map, you will understand. Most of ECMO facilities are in the United States and Europe, right? And these are countries where you don't really get leptospirosis. Now, if you look at the countries which have a lot of leptospirosis, they are not the places which have ECMO. So we are fairly unique because of the situation where we do have ECMO and we have lots of leptospirosis, and therefore we have actually quite a lot of patients on this. Now, these are the results we have had, something which you will find interesting. Over the years, we've had 39 referrals. Some were not actually, ECMO was not indicated. But when we realized that it was indicated, some patients just could not be transferred. They were just too sick, or there were other issues and multiple issues why ECMO was not instituted. And almost all of these patients died. Now, of the 15, this is a very interesting thing because 11 have survived. And because and these are the ones we used ECMO on, and we have lost 4. Now, this is a very important finding for us because we have presented this in ASIO as well, our early results. This is important because one of the problems which we were worried was because this is pulmonary hemorrhagic syndrome. And because we heparinize, this is something we were very worried about. But we found that not everyone bleeds to death, right? Most do very well. And this is a very good indication. And it is something that when you take the world of ECMO, Sri Lanka has the largest number of published reports in the world. So this is something you should know. Now, COVID was a disaster when it came to ECMO because ICUs had to be set up almost overnight. Now, this is exactly how you do not set up ECMO ICUs. And you will all understand, I'm sure all of you have gone through this PPEs. It's very, very, very difficult to do anything with this, leave alone ECMO. And this was a really, really hard time for us. Um, and this is one of the rare patients who actually survived with a lot of hard work. We had to use things like cytosob and for COVID ECMO. And so this was a really hard period for us. And like I'm sure everyone has gone through this in their own way. Now, the present state of ECMO is also something you should know. How do you refer a patient for ECMO? Say you guys you think this patient may need ECMO. And the process is what I think I should tell you. We have an ECMO coordinator, and that is Dr. Kapilani. Although she's a pediatrician, she does this so well. We've just let her do the adults as well. There are standard indications and contract indications, which I will show you in my next slide. These patients all are assessed on an individual basis. If you give a call, you'll be directed to Kapilani, who will send you the ECMO form, which you have to fill and send back on WhatsApp, right? And we make a team decision. So it's not just me, there's Dr. Kapilani, there is Dr. Gihan, who is our intensivist. And we have a microbiologist on our team, Dr. Bhagya, and any other intensive care person, depending on what the condition is. And Dr. Richard Furmin, even if he's here or in the United Kingdom, he's also in the group. So we all make a team decision fairly early about whether this patient will go on ECMO or not. And of course, then to decide whether the patient can be transferred. And then, of course, you have to find a bed in the National Hospital of Galle. So this is the process, and we expect the doctors, the medical officers usually fill this under their consultant. You need to know how to fill this, and you have to send this, the filled form, as well as the x-rays and anything else that you think is relevant to the group, and we will all be looking at it and making a team decision each, and we do it as an individual basis. So I said about indications and contraindications, right? So this again is something you need to understand. The philosophy of ECMO, as I just told about at the very beginning, is that this is to support in severe respiratory and cardiac failure when they are not responding to optimum conventional forms of treatment. And this is a temporary lung or heart support. So if it's a permanent problem, we are not going to do ECMO. So if this is not severe, there's no point in going for an invasive procedure like ECMO. You can ventilate. And but it is only when they're not responding to the optimum conventional forms that we consider ECMO. So now you know the philosophy behind ECMO, and then this, of course, logically means that there are contraindications. So what are the contraindications? If we can't cannulate, now very, very tiny babies, like less than 34 weeks, we don't have cannula that will, fit into these. Again, this goes on to say very small babies, or some are huge men or women who you can't actually, very difficult to access, right? Fat layers are like so big, sometimes it's like really difficult. So the difficulty in cannulation can become a contraindication. Then if you have uncontrolled coagulation abnormalities, this is something you need to watch out for. This was one of our concerns with leptospirosis, but this we have found doesn't affect most of the patients. So we do not use leptospirosis, severe hemorrhagic lung disease, as a contraindication. Then there are irreversible conditions like severe brain damage, lethal abnormalities like trisomy 13, 18. And this is an very important consideration. If it's more than 10 days of ventilation on this, and lesser for COVID, already irreversible changes set into the lungs, and there's no point in supporting because we cannot get them off ECMO. This is why all doctors need to know that if you are going to make a decision, you have to make it early for one thing, before the patient is going to get irreversible lung disease, and also to do it when you can transfer the patient to us. Yes, if you wait too long, you will find that the patient is too unstable to be put in an ambulance and sent all the way to Goa. Right? So these are certain things you need to be aware of, and I think those are the important things medical officers probably need to be aware of. Irreversible extrapulmonary organ damage, you can't, no point in doing it either if it's irreversible. And of course, unless you are considering for organ transplant and stuff. So, what are the complications of ECMO? So, complication rate increases with the duration of ECMO, and the complications are related generally to nosocomial infections and ICU related ones, which are common to every patient in the ICU. And there are ECMO related ones, and which are most prominently bleeding and clotting. And also multi-organ failure sometimes is a big problem. So this is because we heparinize these patients, and then this kind of very, very bad bleeding can happen, and these are complications, which is why a lot of ECMO management goes on about managing the bleeding and the clotting throughout the patient's ICU stay. So we've had 229 referrals to date, 57 runs, and still going. The peaks you see here are during leptospirosis epidemics and then the COVID pandemic. Those are when we have had lots of referrals. Most of our patients have been cannulated peripherally, that is like through the groin or the neck, as opposed to central, which we do in operating theaters. So this is kind of during heart surgery, sometimes we've had to do, not often, but sometimes we've had to do. This year, Guru, I'll be presenting one of the central ECMOs for you guys at the cardiology meeting this year. So that's one of the central ECMOs. And so indications, although I'm a heart surgeon, have been mostly respiratory, but we also do for cardiac as well. And that's another indication. Modes of ECMO, because most of my cases are respiratory, most I do are veno-venous ECMO. And where do we do it? Right now, even up to today, what we are doing is in the ICUs within the National Hospital of Galle. This is the PICU for kids, and this is, as you can see, during the COVID era and in the medical ICU. Additional procedures, we have had to do 44 additional procedures while on ECMO, and bleeding can be a really difficult problem. So we've had to do, these are the variety of procedures we've had to do on patients who are already on ECMO. What you see here is the CRRT and plasmapheresis are being done for patients who are, especially for leptospirosis. And balloon pumps are needed when we are talking, before we actually do the cardiac ECMO, we will always put a patient on, we will try the balloon pump anyway. And then a variety of other things, including delivery of a fetus, had to be done while on ECMO. This is how we had to do a tracheostomy during ECMO. This is a congenital diaphragmatic repair being done by our pediatric surgeon in a neonate on ECMO for a diaphragmatic hernia. This is an interesting case where foreign body aspiration was done, what happened, and the ENT surgeons, we asked them to come and do the bronchoscopy while we supported, because they could not take this out, which was in the carina. So every time the ENT people put in the bronchs, patient would desaturate. So patient was sent to us for thoracotomy, but because we had ECMO, we encouraged the ENT team to do the bronch while we support in the cardiothoracic theater. And this is the entire team came with all their gadgets, and they actually managed to take this off very successfully. And this is published in it's an international publication for us in the Journal of Laryngology and Otology. And this is the bead that this child aspirated. We have actually helped Valisara when asked to do one or two cases. This is one where they had done a pneumonectomy and now they had to do a secondary. Secondary was a small secondary was there on the other side. Obviously, they can't collapse the lung, so they requested our help. So we had to take our team there, and they did this very successfully. It is simpler for us when they bring the patient to a National Hospital Gaul Theatre, and this is that when we were supporting their team to do a post-carenal bronchial cyst excision. And sometimes we just keep Ecmo on standby. This is Dhammika who brought this huge tumor. He was worried about this. We placed the cannula in anticipation to go in Ecmo if we needed, but we didn't really need it. And but they were very happy that and very comfortable knowing Ecmo was available if needed. So we are having a survival of about 50%. Of course, we this total is actually 59 now, and as opposed to you can see quite a lot in the world, and these are the survival data which they have. Then a few pictures that I would like to show you, and although I'm saying our survival is 50%, which is very good considering most would be dead of these patients. Some have very good survival, and we are very happy to say 73% now for our leptospirosis. This is our first patient when he came back later. Accidents have done reasonably well at about 67%. This is seawater drowning patient. We've had patients drowning in pools, these in the sea, and a variety of accidents which have done reasonably well. And of course, meconium aspiration is one of the best survival rates in the world. So this is a witnessed cardiac arrest with very bad meconium, which was managed successfully, and it's lovely to see them grow, and which then is what really makes all this hard work really worthwhile. So education, you've been very, we worked hard on this. This is January 2015, where we had our first training course, and we have courses, workshops, mostly in Gaul, but this is sometimes we take it. This is at Lady Ridgeway Hospital. We've done one in Family Health Bureau some time ago. But having said this, there's nothing like hands-on experience. Remember, these courses internationally come to about 2,000 US dollars. Obviously, even doctors find it, even consultants find it difficult to go for these courses, leave alone sending nurses out and medical officers. But all of these nurses, this is one of my medical officers, these are nurses who support anesthetists. We all learn on the job. And this is a very important consideration. And a lot of people do actually take opportunity to come and see when an ECMO is on. So a lot of trainees are interested. About ECMO around the world, we belong to the chapter of the South West Asian African chapter. Sri Lanka is on the world map here as an ECMO center, and we are members of the ELSO, and this is the mother organization of Extracorporeal Life Support Association based in Michigan, United States, where Professor Bartlett and the crowd actually started it all. They have now ELSO for Europe. We have an Asia Pacific chapter. Then we have the Latin American chapter, but we belong to the Southwest Asian African chapter. We got the membership in 2018, and that's how we put Sri Lanka also as an ECMO capable country. And we have been presenting and at a lot of local forums so that people are aware of ECMO, as well as we've tried to network with the international community, which is also very important. So we presented our statuses like in various meetings whenever we can. And this is an important picture for me. This is Dr. Robert Bartlett. This is myself and Kapilani, where Dr. Richard Furman was also there. This is in New Delhi. So this is over a cup of tea where we can discuss certain things. And this is very important for us because we learn from each other. And the ECMO community is actually a very, very nice community of very enthusiastic individuals who always want to help each other. A new addition to our community has been the Air Force, who have been very interested about transporting patience, and we shall see where we get with this, because we haven't really focused a lot on mobile ECMO, although we got a feel of it during COVID, taking patients all over the hospital. And we've sometimes had to outsource, as I showed you, to Valisara. But this is like so energy intensive that we really need to get our act together within our hospital before we can outsource, especially because if, say, the cardiac surgeons have to go out, it's hard to leave our patients and go out and do another patient if our bypass and our valve patients need to have the consultants and the experienced doctors there. So it is quite difficult unless we have a larger team which we can deploy, but we haven't forgotten about it and it's always on the cards. A question you are going to ask, so I might as well tell you. It costs, this is the roughly the cost we have. So we are talking about about 4 million, I suppose, right? This is last year's figure. So I would say about 4 million. I've just put the numbers for about a bypass now comes to around 1.8 to 2 million, single valve this much. Although I must say, if problems arise, it's going to be much, much more. Um, and the biggest problem here is for the pump head. And we reuse this because we can't actually spend this much money. Oxygenators and tubing sets, we don't reuse, but this is not too bad. But also you have to remember, when you say ECMO is very expensive, remember in Sri Lanka we reuse most parts, and that none of the staff are being paid extra for the work. I am not paid, my nurses, my doctors, nobody's paid anything extra. So you have to understand, when internationally people say ECMO is expensive, yes, it's because the salaries are the largest expenditure in other countries. So this is another factor that actually we have been able to make ECMO work for Sri Lanka. But it has been under very hard, lot of hardship. So we realized we need our own space. So in 2021, we started laying the foundation, and we were designated as the National ECMO Center. Ministry realized this soon after the COVID. So they started building it, and of course, you would realize the economic crisis hit. But we restarted it based on fund. We raised 29 million actually to build most of the ECMO center that the ministry started. So, and all this was funded by family and friends and all well-wishers. And I am very proud to say that in a few weeks ago, we managed to uh, uh, complete the intensive care and the restrooms. Although there's still a little bit more to go for our training center. And we managed to put this board up as well. So this is the National ECMO Center, which you see, which was a lot of hard work. And of course, the other thing is about our journal, and we are about to bring out our second journal as well. Please read the journal, and we welcome all of you to send articles as well. So this is the summary of what I have spoken about. We have looked at how and why ECMO works, the technology and the components. We've discussed the types of ECMO, indications, contraindications, complications, and we have looked at some pictures which show about ECMO around the world. I've given you a feel of what the current survival data is internationally and locally. I'm already telling you about the cost of ECMO before you ask. And about education, training, and research are very important components of any ECMO center. And I have just told you about our recent developments in our own country. So thank you very much.
Thank you, Talusha, for that extensive coverage of ECMO.
Thank you for
We have a few minutes. So if anyone is interested in asking anything, they can either unmute and ask, or they can put it in the chat. I hope you have a few more minutes with us.
Yeah, no problem. And while people are thinking, we are all very welcome to liaise with our team to see an ECMO in action whenever possible. Then you will get a really good idea of like what it is.
Yes.
Although it does happen as an emergency, but if you have friends, they will give you a call and say, Machang, there's an ECMO happening. So somehow registrars seem to find their way in.
I think there is something in the chat which says anemia and Ecmo. So I think the question is,
Let me have anemia and ECMO. What do you want to know?
not sure. It's been mentioned as anemia and Ecmo. Maybe whether it
Okay,
is safe to.
what I will say is that I haven't this time gone into any discussions about the physiology of ECMO because I felt it was more important to give you a feel at this level. Um, but what you will realize is that all the, it's the hemoglobin that takes all the oxygen. So it's not really, we are less worried about the dissolved part. So if you have a good hemoglobin level, you are going to get more oxygen, which is why we keep patients when we are on ECMO on fairly high HB levels. We don't run them around 7 or 8. We like to have them around 10 to 12. So anemia is not a contraindication for ECMO, obviously, but because we transfuse lots of blood, by the way. So it's that, and if the patient has bled and is anemic, even before we start putting the patient on ECMO, we are transfusing. So we have to bring the hemoglobin up, and during we give about 2 or 3 pints actually a day sometimes, Guru, right? So, and we try to keep the hemoglobin about 10 to 12 because it is all about giving oxygen to the tissue, and higher the hemoglobin, the better. I hope that explains that I have kind
Yes.
of answered the question.
Yeah. Thank you. Yes. See, I think it's altogether a new topic for most of those
I know.
listening. So yes.
I
So
know, which is why I haven't gone into the the nitty gritty and the physiology and a whole lot of uh, other things. I've just tried to put more pictures so that just to give a feel of what it is and hopefully encourage you to do a little more reading. And there's quite a lot, uh, even in the now the local journals as well about what's happening. And as I said, Guru, I'll be talking about a cardiac ECMO this time for your conference.
yes.
Um, we have another question, is it? Is it?
They are all
No.
thanking you.
Oh,
Yes.
okay. Okay, you're very welcome. It's been my pleasure.
Yeah.